This is Duke University.
So first I want to say a heartfelt thanks to everyone who invited me to the Humanities Center, the Trent Center, the long list of people that you thanked. When Deborah approached me and Carrie approached me, I think it's been about 5 or 6 months ago to consider this, I thought, yeah, this is great. I'm going to talk about the medical humanities, the move towards health humanities. Yeah, global health, it really wasn't entirely on the forefront of my mind, primarily because it's not on the forefront of medical humanist minds about what these two fields, both nascent and particularly in medical humanities, more established, what they might say to each other. And as over the last several months, it's been probably one of the most invigorating processes for me as a scholar and a member of the world to be brainstorming with, I guess the 6 of us. We've been having really dynamic email exchanges. One of the things that's come up in our conversations about how we might consider the role of the humanities in global health more generally is questions of identity. Who are we as humanists? And I thought I might take a minute to talk a little bit about my odd background, because when I do hear descriptions about what it is I do, I'm like, golly, that just looks like I'm all over the place. And it is true. I think in a way it's been part of a long-standing strategy, not of being a dilettante. To the contrary, actually, is my understanding of what it means to be a humanist. I once got a question not too long ago from someone who asked me, yeah, I look at your CV, I see all the stuff that you've done, but where do you belong? Who are you? I did my PhD in French studies, particularly early modern studies, which means 16th, 17th century, right as the scientific revolution was generating, with an emphasis on theory and literature. I came to Vanderbilt in the late 90s, right at a time where we were getting a little bit, the theory wars were starting to die down a little bit, but they were still quite intense. And there was a move toward, much as a result, I would say, of post-structuralist theory, a move towards interdisciplinary studies. Vanderbilt made some extraordinary investments in interdisciplinary centers. One of them, I'll talk about in a minute, is the Center for Medicine, Health, and Society, which was founded in 2003. And by that time, I'd already moved from my thesis as a graduate student on some obscure 17th century novelist toward looking at questions of history of medicine and literature, primarily because that was something I couldn't do in graduate school. I really wanted to be able to marry these two together, but we really were not, at least in the department I was at the University of Wisconsin, which was deeply theory embedded. I didn't have an opportunity to engage those two discourses. So I did, as a junior faculty member, and wrote a book that was entirely different than my dissertation on the history of embryology and childbirth, which then positioned me to be associate director of Medicine, Health, and Society. And I'm looking at David Boyd, because David, of course, is in global health, and David and I worked more closely than you can even know. So he was at Vanderbilt with me in the early, hard, backbreaking years of Medicine, Health, and Society. And so what I'm getting ready to talk to you about now is a journey that I took with David, and also to be in this context of global health and global health humanities. It just feels like the team's together again. So anyway, so I was associate director of Medicine, Health, and Society, which was an undergraduate program established, and it was the brainstorm of students along with faculty members, specifically some faculty members and one faculty member in particular in history. And it was a humanistic endeavor. And that's why our colleagues from WashU will talk about what they're doing in the medical humanities and building a program that will specifically and forever and always, we hope, remain grounded in the humanities. And I did that for 3 years. Went underground, wrote my next book, which is the book you talked about. And when I came back up, some interesting things happened. Medicine, Health, and Society lost its, it wasn't David's fault. It was actually because he came here. Medicine, Health, and Society moved more towards a social science practice. When I came back up, I also had an opportunity, I'm looking at Anton Zucker, who has been instrumental in developing public-facing scholarship and research in the sciences, and for me as the lone humanist, I started to question what it is I was doing, right? Who was I in the world as a humanist? And a lot of what I really am understanding. It's okay. This is the worst. I do that in the middle of teaching, and when sometimes when students' phones ring, I pick it up and I say, "Hello." Oh, I'm sorry. Oh, is this Johnny's mom? He's in class right now. This is Professor Tucker. But it never happens again. But for me, I think I've over these years, as somebody who started in theory and literature in the 90s, and now here we are, is a growing impatience as a humanist to want to make a difference in the world. And what does it mean using my humanistic training to be able to engage with other communities? Not as a top-down type of experience where I'm going out as, my robe and pontificating, but rather how do I engage in a meaningful bi-directional dialogue that at once demonstrates and bolsters, but also nuances what the humanities can bring to the larger world, but including, and especially with my trajectory, understandings of health. Moreover, how can what I do as a humanist, even if I'm working in the 17th century, what can I do as a humanist that will actually impact current practices of health and move towards a more democratic notion of health should be accessible to all, right? Including low and middle income communities. And that's where we get into larger discussions and actually stopping points, because so much of what we've done as medical humanists is a practice over the last 20 years, as Deborah explained quite well, and it's one I absolutely believe in and will continue to do. So, and what I'm talking about right now is it's not saying, oh, we need to chuck everything that we've done so far. I still have a little bit of a growing impatience with it, because traditionally the courses that I've taught and continue to teach in the history of medicine and then also in narrative medicine are really targeted at individual reflection and practice. So when I teach narrative medicine to undergraduates, many of them will be later on practicing physicians. We do a standard practice of looking at what literature can bring as far as listening to the gaps, to what's said, what's not said, the dialogue, understandings of the body, right? Ways of expressing those things that don't often get expressed in clinical situations in the hopes, or at least aren't recognized immediately in clinical situations in the humanistic training-like frame. But I do that in the hope that when my students will go into the profession as healthcare professionals, not just as doctors, right, is that will help inform their practices. That's a really, 20 years ago, that was a sort of a revolutionary idea, right? Now it's become one of our standard understandings of what the medical humanities, and we'll nuance that in a minute, what the medical humanities can bring to healthcare. There's the other element of history as well. I've found myself having a growing impatience as I've done grand rounds. When the last book came out, no doubt when the next one comes out as well, I had an opportunity to move to different medical centers and do really fun talks about, the last book was on the history of blood transfusion in the 17th century, do really interesting, fun, ethical talks and ground rounds and dean's lectures, and I would have a bunch of health professionals, and they loved it because it wasn't full of graphs, right? Next slide, next slide, next slide. And it got to these larger questions about what it means to be human, how do you understand the underpinnings of your fields. Those are still great, and I love to do those. As Deborah mentioned, I just did one last week on the history of the heart. Now that I've moved into, I split my time between the College of Arts and Science and then what's the Center for the Center for Biomedical Ethics and Society. We have two groups at Vanderbilt, MHS, Medicine, Health, and Society, which is more undergraduate focused, although there's a growing research core, more strongly in the social sciences, even though some people probably wouldn't call it that. And then Biomedical Ethics and Society, which is more on the medical side. And I get to work with clinicians who do ethical consults. I'm not part of the consult team, but they're my next door neighbors. I work with people, I'm in situ with people who do public policy, who look at genomics, the ethics of genomics research, who look at the intersection of faith and healing, but it's mostly in the medical school context. So how are we informing research in the medical school? This is the first time that I've been embedded, if you will, in medical school. And as the humanist, it's been exciting because I'm getting invited to committees because they want a humanist. I'm getting invited to grand rounds talks because they'd really like to learn about the history of the heart or the history of embryology. I get to do all these things, and I will continue to do it. It's really exciting. It's a lot of fun to have different interlocutors. But one of the things that I've discovered is I'm impatient because they all leave, I leave. What have I done as a humanist to advance health outcomes, right? What tangible thing am I bringing? And that's, I think, why when we talk about health humanities and medical humanities, we're at, as you mentioned, well, this conundrum, right? How can we make sure as humanists that we are not just add-ons, right? First of all, we have to define what we mean by humanities, which is a very difficult thing because to my mind, particularly in regard to traditional modes of medical humanities, we have history and literature more as academic domains that traditionally in the medical humanities have been help the practitioners understand better their work. And then we also have, I would call them conservatory arts, art, music, theater, creative arts, which interestingly are considered perhaps more accessible to patients, and there are long-standing and wonderful programs in medical centers and health community centers on therapeutic arts. So what can this bring to a person who is exploring their engagement with the medical field, their sense of body, embodiment, health, illness? All of that is really important. What could this bring to a global health dimension? We're still not quite sure, right? But I do know that I've been part of in this last year some ideas around this that have informed my engagement as a humanist has informed these initiatives. In the Center for Biomedical Ethics and Society, again, the one that's housed in the medical school only for medical students and PhD students working in health-related fields, how do we help undergraduates in that MHS program actually get clinical experience? Now that is huge. We don't want a bunch of undergraduates running around in the clinic, right? But we need to somehow ground them. And one of our approaches, even though I don't necessarily work in ethics, one of our approaches is oddly, wonderfully, amazingly resonant to me as a humanist, is this question of everyday ethics. So much of what we understand to be ethics takes place in those dramatic moments of beginning of life and end of life scenarios. That's the prevailing notion of ethics. But we know as humanists, whether we're working in literature, history, art, music, creative writing, or theater, and I would also say anthropology because I see anthropologists as being very akin to us, even though you guys are often located in the social sciences. What does it mean to be a human being? What does it mean to be part of communities? We have all of these different tools as humanists that we can bring to bear, right, in social dynamics, reading between the lines, looking. So we're developing a program at Vanderbilt right now that gets me really excited around everyday ethics, in which we ground students in qualitative methods, and I'm going to get to the methods gap in a minute. Qualitative methods of observation. What does it mean to observe? What does it mean to observe both people in situ, in a given context? What does it mean to observe in a text, to read carefully the text? What does it mean to observe products that a patient might create using art, music, all of that? And to use the tools, right, of careful, structured observation to be able to offer students an opportunity to talk in grounded ways about what they're seeing, what they're hearing, what they're reading, right, in an ethical frame. From there, we're hoping our students will have an opportunity to sit in and watch interactions in a clinical setting, collect data on that, provide a reference database that would be passworded so that we would have additional, that's when we take a look at discourses and medical practices, et cetera. Have our students also do observations in community healthcare settings, right, clinics, and then also in their own environments as undergraduate students, right? Observations about dynamics in their dorms, for example. WashU, Duke, and Vanderbilt, we look a lot alike, actually, and our students engage in very similar ways. To me, that gets me extremely excited because I'm thinking, gosh, that's perhaps those tools that we're bringing into the observational elements, that's bringing in all of us in the humanities. And that's a lot of what can help inform global health practices, I think. There are really interesting ways that we can do this, but what does this mean for the medical humanities, health humanities, and global health humanities? And I wanted to, if you have your hand out, right? So I guess what I've tried to do is give you a little bit of my odd trajectory. If you don't mind sharing, that'd be great. So what I've tried to do so far is to talk about my odd and hopefully not dilettante background, my impatience of wanting to make a difference in the world as a humanist, different types of terminologies and stakeholding in regard to the richness of the humanities as we understand them. One possibility, which is based in observational grounding. And now I want to go to the problems that we might face when we try to make a shift from humanities, medical humanities, health humanities to global health. And I prepared this as a hopes that we, and I know it seems pretty pedagogical, I've got the little definition thing, but if we're going to spend the entire day talking about global health humanities, and that's an emerging field, we probably need to work together to find a way to find definitions that feel good for us, right? So let's just look a little bit, after having given this overview, at some definitions. So if medicine is the science or practice of the diagnosis, treatment, and prevention of disease, very clinical. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, WHO definition that's been prevailing for decades. Now, there are two books that have come out. There's been a shift recently from medical humanities to health humanities, specifically trying to get that fetish out of the clinic, right? The humanities as being something only for the providers and only for patients, right? So the individual practice, and specifically around the science or practice of diagnosis, treatment, and prevention of disease. So there is a movement afoot, and an interesting movement afoot, that looks at health humanities. I'm going to pass these around. This one, I don't even know that it's available yet. It's out this year. Health Humanities Reader. And this one's exceptionally good. Health Humanities is coming out of a team from the UK. And I looked at this in preparation for, I looked at these two texts in preparation for my talk, and I thought, this is great. This is going to really help me figure out how we can move. So we've got to make the move from, not move, but we need to expand medical humanities to health humanities to global health humanities. These will give me the answers, because if we start to move to health humanities, we'll get closer to global health humanities. I'm not sure we're there yet. There's not one global dimension. They're fantastic books. There's not one global dimension in these books, interestingly enough. In addition, in opening it up, in Jones, there's a quote that says, by very disciplinary descriptor medical, it remains a narrow frame, largely concerned with the value of history, literature, philosophy, art, and media to medical education and medical practice. And there's a suggestion in the Jones book is that we need to have more inclusive, outward-facing, and applied discipline, embracing interdisciplinarity, and I can't think of a field that is more interdisciplinary than global. And engaging with the contributions of those marginalized from the medical humanities, and I thought, yes, such as allied health professionals, patients, and informal caregivers. I thought, we need a broader concept. We need a much broader concept. And I love the reader. It's a great reader, but so much of what I was already reading was some of the stuff I might have also called medical humanities. In addition, there's no reference to the global notion. Now, Duke is fascinating to me. Largely, I've interfaced and gotten to know the program through David and Deborah and Carrie. What you guys are doing in that major is, I told David a couple years ago, it brought me nearly to tears when I read the description because it is so unbelievably thoughtful. It engages the idea of having core courses in the humanities that are not a track, right? That are integral to your program. And it dovetails so beautifully with the mission statement of the center itself, the undergraduate major does. DGHI works to reduce health disparities in our local community and worldwide, recognizing that many global health problems stem from economic, environmental, political, and healthcare inequalities. DGHI brings together interdisciplinary teams to solve complex health problems and to train the next generation of global health leaders. Now, I can see if I read in, make some inferences, more inclusive, outward-facing, apply different disciplines, embracing interdisciplinarity, engaging with the contributions of those marginalized, which I think is of an important notion in global health initiatives. I really want to see if we can find a connection between these two, right, that go beyond expanding out, and I'm reducing their argument. They actually have a very lovely argument, but such as allied health professionals, patients, and informal caregivers, is if we can find a better connection between those two. I think we're touching at a similar willingness in the health humanities to expand, to get to the so what, to look at more global understandings of what it means to be a person with physical, mental, social well-being, not just in the United States or in the UK, but worldwide. And my sense, the more I think about it and the more we discuss it, the humanities is right here. We are the ones as humanists who can help bridge those definitions. So as I started to think about it, I started to think about what has originally created some walls, if you will, between the humanities and what we might understand as global health interdisciplinary practices. The humanities, we've been long anchored in questions of disciplinarity. I specifically don't say anymore that I am a French professor, although I am. I believe broadly in modern foreign languages as a area of inquiry. I don't say that I'm a historian anymore. Since that's what I do, is I work in cultural history. I say, as a practice, I'm a humanist, because that embeds all of my methodologies, and it allows me to interact with Rebecca, it allows me to interact with Deborah, with David, and anybody else here who's in history and all of those fields. STEM has it, we should be able to have it. And that will take us closer, I think, towards a spirit of interdisciplinarity that will help us be able to create a better bridge between medical humanities, health humanities, and then eventually, hopefully, global health humanities. Other sort of sticky points that we've had historically, as I mentioned earlier, is the theory, the notion of predominance of theory, which is very important, is to say that practice in health dimensions and global health dimensions is not a theory-based practice is ridiculous, right? Is you have to go through this with clear understandings of what well-being is, how people are in the world as complete physical, mental, social persons, right? We have to have clear understandings about what it means to have a body, what it means to be in relationship with that body, what the political, economic, religious dimensions are, right? But if we are too much in the world of theory, which many times humanists, we believe that that's what we do, right? And that's what we get increasingly accused of, is if you listen to Fox News, for example, and all the pushback against higher education. So we've got to think about ways that we can move from theory to practice. We also, as humanists, we tend to say that we're engaged with the individual practices, right? I work in the early modern period. You work in 18th century Enlightenment. We know that theater, literature has always been this individual understanding since Aristotle, as if I read it, I will have this catharsis, and it's a relationship between me and the text, right? But as humanists practicing, and somebody who works in cultural history, I know that I look at individual text, on their own merit, but I'm always and forever trying to get an understanding of how those texts operate in dialogue with one another, and how those texts are both a product of and also and they produce a larger worldview, right, that allows certain things to be possible and not possible at a given time. And I believe that that is something that I keep looking at Carrie as a practitioner out in the field, is that those types of understandings are critical when it comes to trying to make real progress in health outcomes, right? So and the other thing is privilege, individuals and communities, right? Privilege, a lot of what we do as humanists, we're in the, we're at Duke, come on. I'm at Vanderbilt, you're at WashU. And how we take those spaces of privilege and actually engage in meaningful, responsible, ethical, and respectful ways in those communities that are not part of our worlds as individuals, as academics. I come at this as a first-generation college student who finds herself, actually first woman, my father has a college degree, finds herself at Vanderbilt University. And I think that's why that was my first job, and I think that's why I'm perennially uncomfortable with this idea that whatever I'm going to do is going to be located in this tower and not making a difference in the world. It feels selfish to me. And so is there a way that what are the ways that we bridge these things? Humanists also tend to work in the written word, at least for us, as me as an early modernist. I wish I had, I could listen to what they were producing in music and speech. Global health, and I'm simplifying, and I want us to nuance these later, but we rely on real-world engagements. Would that be right? Is listening, taking oral histories, being present in clinics and public and community settings. How do we make that transition? Teaching, and this is something I've also believed in deeply, is a lot of times medical humanists, sort of more traditionally writ, is our job is to teach those who will do, right? And increasingly, we know with, for example, service learning and engaged learning, is how do we take that teaching and move it out into an engaged context? Because that's what global health is, right? Is going out and engaging with communities. And then I think, then we get to my point of real thinking that, in the end, humanities and social science, how do we bridge what are essentially two different sets of tools, methodological tools? Social science, again, I'm completely making this caricature for productive reasons, I hope, is that when I take a look at some of the work of my colleagues in medicine and also in global health, I see biostatistics, I see epidemiology, right? I see quantified measures, as well as, I would say, qualitative stuff. Those are practices that the qualitative stuff, qualitative methods should not be all that unfamiliar to us as humanists. We just don't work in vivo, right? But the types of close readings that we do on our text we are able to dialogue with those who do grounded theory in qualitative context. We can engage with that. I look at some of the biostatistics and I'm like, I don't know what that is, right? It's a dialogue that is very hard for us to have because we have two different, if we imagine a Venn diagram, one circle, we have the other circle, we're having a hard time figuring out how these are going to intersect, right? Because the languages are very different. So this gets me, well, before I get to the so what about all this, I've continued the lines here because I'm feeling that we could probably do more types of dichotomies and perhaps discussing the types of dichotomies and then also discussing the ways in which those dichotomies may not indeed be dichotomies, or at least being aware of those dichotomies and then figuring out how one or the other and both could move more towards the middle. Is perhaps that would be an entry point into a larger discussion about where the humanities can be in regard to global health initiatives. And then perhaps later, and I would just encourage you, we've got some models, and perhaps those are already lurking around. I just didn't find a lot of definitions of global health humanities. Can you think
Here's the single one.
Yeah. And so that's where I started.
We're doing it right here.
That's where I started. I was like, I Googled global health humanities. There's not a lot. Oh, interestingly. And so I thought maybe that would be a first step, is to try to come up with a definition that fits for us. So let me go back to this last one of humanities and social science. And I realized I didn't even show you my slides, and that's fine. Just know that, well, I guess maybe I should back up so you can see why those references are there. And I had the hardest time formatting the references. Here's the other language thing. How do I format these? Am I going to use MLA? Am I going to use APA? What crowd am I with? Already it's a languaging issue. So I don't need to show you the slides for these. The music enrichment programs involving the neural encoding of speech in at-risk children. Oh, so I picked all 4 of these because the biggest question when I see these studies that ostensibly are using the humanities or engaging the humanities, I'm always asking myself, what are the opportunities and risks for the humanities in these studies? Are the humanities actually full partners in these studies, or are they at the service of other fields, or are they being instrumentalized? These studies, I've picked these 4 studies because not because they're problematic in and of themselves, but they offer opportunities. In fact, let me just flip through. So the first one, music enrichment programs improve the neural encoding of speech at at-risk children. It's too small to see. Essentially what they're doing, musicians are often reported to have enhanced neurophysiological functions, especially in the auditory system. Music training is thought to improve nervous system function by focusing attention and meaningful acoustic cues. These improvements, We therefore provide the first direct evidence that community music programs enhance the neural processing of speech in at-risk children, suggesting that active and repeated engagement with sound changes neural function. It's making an argument, right, for enhancing musical programs. As a humanist, I love that. I love that. As a humanist, I look at this and I say, is this really engaging humanistic practices, or is it engaging humanistic products, right? Are we being instrumentalized? Are we a service? Or are we fully engaged partners? This is not to undermine at all the benefits of these studies. The second study, methodological challenges in cross-language qualitative research, a research review. Squire's work is really interesting for those of us who work in the languages, because she's very interested in looking at problems of translation, also to qualitative data. She looks at some of the untranslatability, I think, of data in the field in global health. And I know that you've been working on questions, all of you, on questions of risk, the terms risk, and risk and resilience, what those terms mean in another language setting. And that's what we do, that's a humanist practice, is looking at the polysemy, right, of terms, and how that can help us understand that our presuppositions that those communities with which we are working in a bi-directional type of way, we may be speaking, even though we think we know the terms, we may be speaking at odds sometimes because we don't understand the rich semantic dimensions around this. So I'm not undermining this work, but cross-language qualitative research occurs when a language barrier is present between between researchers and participants. The language barrier is frequently mediated through the use of a translator or interpreter. The purpose of this analysis of cross-language qualitative research was threefold: review, synthesize, and then test these criteria. What she's doing is she's looking from, this is interesting to me as a language professor, right? Because our first engagement, perhaps, in global health would be our language skills. Problematized as it is, because when we look at the modern foreign languages, French, German, Spanish, Portuguese, colonizing languages, moving into the global health context, there's a whole bunch of social, political, historical, economic dimensions that we need to be attentive to. Typically, what I've found in healthcare settings, if I'm not moving into it as a medical humanist in literature and history, I'm asked to come in as a language teacher to teach those who are going to go out in the field, right? That's great. I think it's really important. But am I really being a full partner? Our job, and I believe here, Squire's work is nice because she's showing just how complicated the whole notion of translation is. It's just not coming in and having a service provider, right? That service provider actually can texture, sometimes without even you aware of it, right? Can texture the types of dynamics, the data you get, the types of interventions you can make, and also the bidirectional community building that you can do. So that's the other thing. Are we being instrumentalized? Are we a service? Are we full partners? There is, oh, golly, let me get back in here. 5 minutes, I'm finishing up. This initiative here is one that I think is so very interesting. It's called How to End Poverty in 90 Minutes. Is anybody aware of this? And it's a project I can't wait to work with at Vanderbilt next year. It's a theater group that came together out of Oregon in which they do community action and development and engagement and research and dialogue to create 90 minutes worth of one-act plays around issues of poverty. And they bring, the audience members are direct participants. And it's not sort of a top-down teaching moment. It's rather an engagement is what does poverty mean? So it's a discovery in the theater. One of the things that I really like is that it engages everything, right? All of these modes. Theory, individual communities, written word, teaching, engagement, humanities, and social sciences. And so in an audience participation in a deeply humanistic context is that during the process of this, they brainstorm, they work together. The entire theater has $1,000 to vote to give to one community organization that they believe will make a difference. And these types of engagements, whether or not they could be applicable to a global health setting, are exciting to me because you necessarily have to get the humanities. You have to get the social sciences in. And you're also engaging with not just the grant makers who are your audience members, right? You're also engaging with community organizations, and you're coming together to solve poverty in 90 minutes, which wouldn't that be nice? But so here's the question for me, and I've got 2 minutes. I know we've got to find a methodological third space. We really do. Imagine those two circles, bring them together. That's where interesting things will happen. It's where the humanist actually can engage with the social scientists, can engage with those on the ground in full partnership, and it may mean some of us learning some new languages on both sides. The other part for me is closing the gap as a historian. It's so important because I keep looking at Rebecca as my 18th century person. My ongoing work is in the scientific revolution. The reason why we have to come together today is because science and medicine during pre-scientific revolution were part and parcel of the same thing. The humanities, the sciences, and medicine existed together in the same space. The reason why we have never felt, I'm oversimplifying, but the reason we have never felt that we needed to justify our existence as humanists is because those very processes, those very disciplines that we are now saying, where do we fit, used to be ours. Science was using, and natural philosophers is what they were called, scientists and doctors. The natural philosophy that turned into science actually was built on the humanities. Nobody ever had to justify us. We were absolutely part of that. So we need to take the two Venn diagrams, find a middle ground, and then to do that, we're actually going backwards, which is really exciting to me. And so that's where, when we get a pushback from our colleagues, and we can talk a little bit about curriculum development in a minute, and the pushback you get, is this a question of seeding territory with a C, or is it a question of seeding it with an S? And I believe firmly that we're seeding it. And if we're going to make a difference in the world, we can work together and find a new definition, and then bring these dichotomies closer to one another. So thanks.
Produced by Duke University, online at duke.edu.